Before I introduce the panelists today, I want to talk a little bit about healthcare and why this is so special and why this time is so special. The healthcare sector in the United States is going to change dramatically in the next few years. The recent passage of the Patient Protection Affordable Care Act in January, signed by the President in March, is the latest in a long history of attempts to reform the healthcare system. Today's health reform includes three major initiatives. First, expanded coverage, with an estimated 32 million newly insured through Medicaid and private subsidized coverage. Second, insurance industry reforms that include health insurance exchange, premium reviews, guaranteed issue, elimination of lifetime limits and pre-existing conditions. And third, delivery system reforms that enable comparative effectiveness, coordination of care, transparency of practice and health information, and value-based purchasing. These three reform initiatives incorporate the lessons learned from the past reform efforts as they emphasize the desired outcomes of providing value through high quality, low cost. Being healthy, helping the population be healthy and become healthier, and monitoring the performance of the system. The continued funding of health IT underscores the importance of IT to change the care models and achieve the stated performance goals. Some of you may know that health IT got a lot of funding with a stimulus package. There's continued funding under this particular legislation. So that this latest reform legislation recognizes the increasing utilization and rising costs of health care as the population ages and the system becomes more complex. The concept of accountable care organizations is emerging. Now, one of the things I just want to clarify, I want to give you some background, but I want you to know that if you are not new to health care, and we'll find out in a minute, this may make sense. If you're new to healthcare, we will ask the panelists to kind of qualify some of their comments so that it isn't too specific to some of the technical aspects of healthcare. The goal of an accountable care organization is to encourage hospitals and physicians and other community-based providers to integrate care, such that the financial risks and rewards of potential savings of doing that are shared. This integration is accomplished by having both parties be collectively responsible for creating, implementing solutions to improve the quality of health care. To bring this concept to a reality, a 3 to 5 year Medicare pilot project is underway to see if ACOs can actually lower costs and improve care. The current health IT landscape has limited electronic medical record, electronic health record penetration, as well as limited health information exchange, and is inefficient to address the demands of emerging healthcare delivery and business models. The new health reform legislation supports the known critical success factors of health IT, which are the effective use of IT at the provider, patient, and system level, the integration of data across multiple settings, and finally, the synthesization of data for performance monitoring and decision-making. So we know what the problem is. The question is, can we get there from here? As healthcare providers and government policy programs, healthcare insurance and IT industry work to balance the high cost of healthcare with an affordable, quality care for all citizens, health IT has an opportunity to truly transform the healthcare industry. So with that introduction, I wanted to give you some context. How many people in this room actually work in healthcare or are in some sort of healthcare-related business? Oh, good. Okay, so we got about half the people, so that helps the panelists. And as I said, you'll have a chance to ask questions. And if there are, and in addition, afterwards when we're done, some of the panelists are staying for the networking event. So if there's something specific you want to ask, you'll have that opportunity too. So I would like to take this time to introduce our panelists. starting here with Julie Bond, who is currently the CIO for the Centers of Medicare and Medicaid Services. Since May 2006, Julie has served as CIO and Director of the Office of Information Services at CMS. She leads a staff of over 350 people, a cadre of several thousand contractors. Julie is responsible for the major information technology development projects. Julie joined CMS in September 2000. Her recent accomplishments include designing and awarding an innovative enterprise system delivery contract vehicle, a 10-year multi-billion-dollar procurement for application software development and maintenance, and implementing, this is mind-boggling to me, this next one, implementing the CMS Integrated Data Repository, an IDR, a 10 billion row and growing relational database that integrates Medicare program data from 2006 to the present. The IDR was a critical component of CMS's recent development as a Medicare dashboard that presents Medicare hospital insurance statistics in an interactive, user-friendly way. Julie holds an MS degree from Johns Hopkins University and an MBA, BS degrees from the University of Maryland. Welcome, Julie. Thank you. Next, I'd like to introduce Bill Fandrich, who is the current CIO of Blue Cross Blue Shield in Massachusetts, and he is in the middle of the storm right now. As we speak, we talked earlier, and he was meeting with the CEO, the new CEO, who was a former CEO there, and they are front and center on responding to the state initiatives for health reform in Massachusetts. As you know, we've been into this for a few years here. He joined Blue Cross Blue Shield Massachusetts as CIO in October of 2008 as the company was embarking on an implementation of a new IT operating model in response to the transformation of the industry. This transformation addresses all aspects of IT organization: sourcing model, technology, informatics strategy, talent management, and delivery model. Since that time, Bill and his team have worked with the entire organization to create a technology plan and vision that will better enable the business to realize more value through information-based technology solutions. As a thought leader in healthcare IT, Bill is also leading Blue Cross Blue Shield Massachusetts in identifying innovative product and service solutions to meet the many challenges associated with healthcare reform. As you will hear today, he's currently involved with key statewide leaders to respond to the ongoing implementation of health reform in Massachusetts. Bill holds a BA from Ohio Wesleyan University and an MBA from Weatherhead School of Management at Case Western Reserve University. Welcome, Bill. Next, I would like to introduce Sue Shade, who is currently the CIO of Brigham and Women's Hospital. Brigham and Women's is a 777-bed nonprofit teaching affiliate of Harvard Medical School and a founding member of the Partners Healthcare System, right here in Boston. Sue has 25 years' experience in healthcare information technology management. Her experience includes 12 years in positions of increasing management responsibility at a large integrated delivery system in the Chicago area. Following that, she led the software division for a startup healthcare software outsourcing services vendor. Under her leadership, Brigham and Women's has been presented with various prestigious recognition, including the HIMSS Analytics Stage 6 honor for its EMR adoption model, the CIO 100 Award for implementing the balanced scorecard to improve hospital performance. She holds an MBA degree from Illinois Benedictine College, and she has achieved fellow status with both HIMSS and CHIME. Welcome, Sue. Thank you. And finally, I'd like to introduce Dr. Chris O'Connor, who is currently CEO of open source, and let me just get to my page here, of Open Source Order Sets, OSOS, a web-enabled collaborative order set solution, including a library of over 400 evidence-based practice order sets. OSOS was founded in 2006 and has grown to a network of over 100 hospitals in 4 provinces used to support quality and patient safety. OSOS has created a collaborative ecosystem to leverage the expertise of healthcare professionals from across the network to realize the many benefits associated with effective order set use, including quality of care, reduced costs, and increased computer physician order entry effectiveness. Before starting OSOS, Dr. O'Connor was the Director of Medical Informatics at Trillium Health Center, an 800-bed hospital located just outside of Toronto, Ontario. Dr. O'Connor is a practicing critical care physician, having completed his medical degree at the University of Toronto. In 2007, Dr. O'Connor received the COACH, Canada's Health Informatics Association, Emerging Leader in Health Informatics Award. Welcome, Dr. O'Connor. So, with our 4 panelists, as you can see, we've covered the landscape. We've got really interesting perspectives. And what I'd like to ask, starting with Julie, and to go across, is for each of them to speak briefly about the challenges that you're facing in your position today and how you see yourself and your organization facing health reform.
Thanks, Amy. I'm really, really happy to be here today. I spend a lot of time, as I'm sure most of my other panelists do, in sort of healthcare settings and healthcare IT settings, and so it's actually really stimulating for me to be in one that's a little bit less focused on healthcare. With that said, we are going to talk about that today. About half of you raised your hands when we asked if, or Amy asked if you work in healthcare, but how many of you are healthcare consumers?
Well, everybody.
So now, you know, everybody gets kind of interested at this stage of the game, because either we're taking care of ourselves or a family member, and then healthcare information technology becomes something that's much more important to us, and healthcare reform. So at my agency, which is, we're actually a relatively small federal agency, believe it or not, about 4,700 people, and we're part of the Department of Health and Human Services, the federal government agency. And our job in Health and Human Services is running a couple programs that you might have heard of, Medicare and Medicaid, and also the state children's health insurance program. Now, in the, of course, Medicaid program and CHIP programs, we run in very tight partnership with states in the United States. So the result of those programs is that we purchase a third of the health care in this country, and we're 20% of the federal budget. And so when we look at things like, or when I look at things like healthcare reform, and internally inside the agency, we call it PPACA, although they're trying to make us stop saying that and call it the Affordable Care Act. But when we look at that, we start saying, well, how do we get that implemented and not screw up everything else that's running right now? And it's actually, from that perspective, it's not unlike any other IT challenge. I think the challenge for us around the Affordable Care Act is that it is just so large, and a lot of what Amy talked about in summarizing the bill, she scared me a little bit because I've never heard it all that fast together. Most of it's going to be implemented in CMS, in our agency. And I have a colleague that said to me, called me up one day, he was in sort of absolute desperation because he has a bunch of policy people that work for him, and he said, Julie, he said, you and I know there's only 2 things in government. I said, what are they, Terrace? And he said, policy and systems. And without systems, policies are just interesting ideas on paper. So right now, this is an interesting 2,000-page piece of legislation, and we have the task of getting that implemented. While we're also, by the way, implementing a big chunk of the Recovery Act that was passed the previous year called HITECH, which I'm sure you're going to hear more about. That's an incentive payment program, and I'm sure I'll get the opportunity to talk more about that, so I'm going to stop. But that's really what we're looking at, is this major IT challenge to implement all that.
Great. Thank you. Bill, go ahead.
Great. Well, when I was asked to say a couple words, I was thinking about the wisdom I might share, and I think the best wisdom was walking in, and I saw there was a previous session going on and talked about becoming a CIO. I almost took all my self-control not to open the door and say, run now.
Right. So, get out quick.
But yeah, it is, who would have thought in healthcare things could be this dynamic. And let me, as we talk about systems and technology, I think what's most important is you really have to, like any business or any situation, decompose the problem in how you're solving it, because technology alone will never solve it. And there are some things in our system today that even, I think we're doing here in Massachusetts differently, that will make technology even more valuable. But just start at the basic problems of what we're trying to solve as a country. You know, it's a $2.5 trillion business, healthcare, going up to $4.2 trillion. You know, we spend $8,000 or so per person, which is 2.5 times more than the average developed country. If you look at our healthcare, you know, what's driving the cost of healthcare? You know, forget the noise, you know, medical cost trend. It's, you know, cost of procedures vary 200%, service provider to service provider. It's been well documented by government studies. There's probably 30% waste in the system relative to unnecessary tests and procedures. You're talking about $700 billion in unnecessary care, and yet we still have an uninsured problem. You know, we've got other issues out there associated in healthcare around just lifestyles. You know, in 1990, there was over 10 states that reported less than 10% of their population in obese state. No one reported more than 15%. Today, there's only one state with less than 20%, and 32 states more than 25%. You know, you got also the issue around selection, adverse selection. That's an insurance thing, but it's very relevant to the cost of health care. Very simply speaking, you know, you need about, 293 people that do not receive care to make up for one premature baby. You know, that's the balance of how you keep the health care dollar spent. Now, all that, and yet, will people say we have good quality health care? And why is that? And if you start peeling it back, and that's where I think tying it to Massachusetts and some of the things we're doing here, we're in the second wave of it. I think we're all very proud here in Massachusetts that together we work very hard to deal with the access issue, what's being talked about at the government level. However, there's implications of the access issue. A lot of the things people thought when everyone had health insurance didn't really pan out. The cost of health care has not gone down. People aren't healthier. People aren't using preventive care any better. There's a lot of implications to that. And there's reasons for that. Again, we're moving into the second wave. Forget what's going on with the noise around rate cap. You know, we've been working a lot with our provider partners to try to reshape that basic relationship. The basic incentive system today is wrong, the way we pay for services. And we've been instrumental working with many of our provider partners on implementing new contractual relationships. We call it alternative quality contract in global payment. In other words, we pay for quality. We start paying for the providers to start being able to do more time with patients in the preventive care and making sure they're getting their treatments to prevent these diseases or prevent this unnecessary care. They're incented to do that. We're getting away from that arms race where we would all fight about the rates per unit, but the units go up. You know, that's the model we're moving towards significantly in Massachusetts. And now, how does that tie to technology? That now opens a door where our technology can be shared and leveraged across all parties and more useful throughout the continuum of care and gets us aligned to the right incentives. So it's a pretty dramatic change we're going through here, and we're pretty excited about it.
Great, thank you, Bill. That's great. Sue?
Okay, thanks for having me here today. I'll be talking more from a provider perspective, which means, you know, you go for care in a doctor's office or an inpatient setting. It's all about the systems that support that care team. So I'm going to try to take it from kind of in the trenches to some of the key things that we're doing and challenges out to the broader view in terms of accountable care organizations. If you think about clinical care, you have electronic medical record, which we have fully deployed with 100% of our primary care physicians and specialists at this point in time, something that most organizations have not yet done, but we have managed to accomplish that. Within Brigham and within Partners Healthcare. We have an physician order entry system that we've had in as early adopters since the early 90s. That's something that many organizations still haven't done yet, but certainly need to do. You have what's called electronic medication administration record, or EMAR, so that at the point that a medication is given, once it's ordered through the electronic system with all the right decision support, you know that the right drug is being given to the right patient at the right time and the right dosage, and then and that's fully in place. One thing that we have not yet done, but we are actively working on with our sister hospital, Mass General, is what we call acute care documentation. So all the clinical documentation and notes in the inpatient care unit will be electronic once we roll that out. It already is in the ambulatory setting, but not in the inpatient setting. So that's where we are. That's what we've done. We're continuing to move forward with all that. Many organizations are not that far along, and when you talk about the ARA stimulus package, High-Tech Act, and meaningful use. Meaningful use is about meeting 25 key criteria that make up meaningful use, though the rules are not final yet, using a certified product. And there is incentive money over the next 4 years for organizations through Medicare and Medicaid if they achieve meaningful use with a certified product. And then starting in 2015, there are penalties that will come through Medicare and Medicaid. So if you don't get to a certain level and receive that incentive money through the reimbursement system, you will then be penalized. So a lot of organizations right now looking at what they need to do to get there. Even an organization like ours that has done so much already has some gaps when it comes to meaningful use that we too have to fill. If you talk about interoperability between organizations across the continuum of care, this is another component of meaningful use. It's something that we've been working on, lots of activity at the state level. What used to be called RIOs are now called HIEs, Health Information Exchanges. That's really about, I kind of look at it a couple ways. One, it's for the greater good. If you are being seen by a physician primarily at Brigham and you are somewhere in, down on the South Shore and you have an accident and you're taken to the South Shore Hospital emergency room, well, ideally, those emergency physicians could get at information that we have about you so that you could get the best and safest care. Having basic information flow through health information exchange in the region is what's going to enable that. And that's, for the greater good. You also have relationships between individual hospitals from a business perspective where, without working through the HIEs, they're trying to do some of that exchange already. So that's happening on two levels. And I think that just will, help us move along as into shared risk and accountable care organizations and a greater level of integration of systems. So I know we'll get more into that.
Great, good. I'm hoping to talk about that. Chris?
Great, thank you very much. Great to be here. I think we're at a fascinating time in healthcare right now. I think it's very interesting. When I graduated from medical school in 1989, which is now quite a few years ago, they used to tell us that, we can comfort always, but in most cases there isn't a lot to do. And they said conditions like heart failure, if your heart doesn't pump very well, we basically had 2 medications that we could give people. We now advance 20 years. I've got 15, 20, 25 different things that we can get to the patient. So there's been a huge proliferation of these effective but also expensive treatments to the patient. At the same time, in terms of where we are from a healthcare information technology perspective, we're mostly not like the Brigham, as you've pointed out. The Brigham sort of stands out for how unusual it is. We're mostly in a view-only mode. So if there's a scale called the HIMSS Analytics Scale, overwhelmingly American hospitals are a place where you can look at patient data, but it does not impact clinical workflow. So they've got their lab results online, they've got their x-rays online, and you can look at stuff, but cross over to the part where you start to impact clinical workflow, and very few organizations are doing it. It's clear going forward that if we're actually going to start to make the changes that we need to be successful, that's got to change. And that's where this era of meaningful use comes in. They want to stimulate us to change what we're doing. And I think you can get lost a bit in the details of ERA because there's 25 different things, but I think they fall into 3 big lumps. One is health information exchange, which they're going to do. I think one is adoption of electronic medical records, and then on the inpatient side by primary care practitioners, and then on the inpatient side, implementation of things like computerized physician order entry. And those are the 3 big groupings. We'll talk about it later. I think health information exchange, it's a clear good. I think that will work very well because it's kind of process neutral. I think CPOE, we're in for some interesting times there. But I think this is where we find ourselves today. I think how well we meet this challenge as a healthcare IT will have a huge impact on how successful these reforms are.
That's wonderful, Chris. Great. Thank you very much. It strikes me that as I was listening to the session before lunch, that there are many similarities across industries and the healthcare industry related to IT. You know, listening to the CIO from Iron Mountain talk about the goal of really eliminating the business process infrastructure sort of barriers to achieve the business goals. That's really a goal of IT to facilitate and enable those goals. So, you know, we're looking at, you know, this time around with health reform, you know, our business goal is to create value, to really improve quality and reduce the cost, and at the same time monitor whether we can actually achieve that. And so my question to the group, and you know, you can just jump in, whoever wants to go at it first, is, you know, will health IT really create value? Is that a realistic expectation? Is that doable? And what, how do you see other industries that might be good role models for us as we think about the idea of not just doing it, but accelerating it, actually making it happen? So I'm just going to open that up, and whoever wants to jump in on that.
Okay, I guess I'll start, because I'll just start by setting what I think kind of is the framework. In the Journal of Health Affairs in April, there was an interesting article which looked at the use of healthcare IT as it related to outcomes that you care about. And they had low adopters, middle, and high adopters. And what was striking about it was how there was absolutely no impact. It was, you know, and I'm sure I see some nodding heads here. I think that's the starting point for our discussion if we're going to have a talk about healthcare IT making a difference, because that's a very interesting result. Just a few quick comments. One is, healthcare IT already does a huge amount of good. Like in terms of looking at all this information, clearly valuable. Things like PACS system, looking at radiology on computer screens, enormous value, and everybody's adopted it. So people say that, you know, healthcare doesn't use IT. Absolutely not true. When it provides value, I would argue they take it up very quickly. Where you're not seeing the impact is at a system level yet anyway, is with this more advanced stuff. So I think that's kind of the starting point for this discussion.
Right. Great.
If I might add, I think one of the places, when I read that question, it was kind of, I thought of a story. And the story is my grandmother, who's a 93-year-old Medicare beneficiary. And last year fell in her apartment and fractured her hip. Although she says she fractured her hip, which made her fall, but that's her. So she had to go to a hospital and get her hip replaced, and then she went to a rehab hospital. She had a little setback there and got transferred by ambulance to another hospital, and then to a second rehab after that. And the story really is about from rehab hospital 1 to hospital number 2. And I was on my way home from work when I got the phone call that they were shipping her in an ambulance to this other hospital. So I turned around and drove back to the hospital, which I did ask, can't you send her to the first hospital? And they said no, for some reason. And so I finally get there. This is sort of a longer story than this, but when she finally gets seen, right, the doctor says to me, walks up to us, and she's laying on a gurney there, and says, so, what brings you here tonight? And every one of these institutions has touting on their website their fact that they're using EMRs, and they all are rolling around the carts and doing that stuff. But the information is not easily movable from one place to the other so that it can actually get used. And if you asked me, would it have value? Yeah, it would have been incredibly valuable to me that night if the information had come across and they hadn't had to repeat all the tests that they had just done at the rehab hospital, let alone how we would go about paying for all that care. So I think that's the issue, and I think that sort of gets to Chris's point, which is this becomes workflow and business process issue, right? It's not in the workflow to get the information from the other hospital, right? What I do is I come up and I start asking the patient and their family what's going on. And so I really think that that's the ultimate problem that we have to solve. And I think that standards will help to do it. And then the industry model that I see is sort of financial services, that, you know, there's been standards that have built up around that. And now, you know, I just expect that my financial data will come to me and go into my way I like to manage my money.
Interesting. So. Bill, do you have any reaction to that?
No, I think it's, it kind of made me, I was thinking about the story too. When you talk to a person who is a user, consumer of healthcare versus us in the system, and we hear a lot of dialogue about privacy and security and concerns, and then the average person does not realize when they walk into an emergency room in Brigham West Side and places like that, there isn't they have the faintest idea of anything about you. They don't know what drugs you're on. They don't know what allergies. They don't know what tests have been ordered. They don't know previous conditions. They don't know anything. And then you get into, well, we don't want the information shared because of privacy. Well, no one wants their information shared, but they do want it when it's about care and living in their health. And that's where I think the system, it's not connected to the realities. I think there is an absolute important need that all of us start to understand the importance of that information being used for the right reasons. Now, here in Massachusetts and now at the federal level, this information cannot be used for medical underwriting or for denial of care, and we haven't been doing that for years here, but there's still this constant push of, no, you can't share it. We fight that battle every day. So let's take a look at our situation. I reminded, like this morning, you know, I'm 15 to 20% of the entire company's cost structure is IT for a health company. And so in the old world, you know, that was claims processing, call center, service desk. In the new world, and that's a big part of shifting, it's information, and then how we use information and how we share it. So let give you a perfect example. The vast amounts of information we have about the individuals that are part of our health plan, whether it's claims, self-reported data, pharmacy, lab, we have technology today, not we created, it's available in the industry, you know, called predictive models. With a high degree of probability, we can determine who is going to have an inpatient stay over the next 12 months, who's going to have to have an MRI ordered, who's going to be susceptible to diabetes if they don't stop or change their behavior. Now, wouldn't that be powerful information if made available to the doctors, to the person? That's the kind of power that is available that hopefully can lead to not only the process changes, the cultural changes, but also, you know, the systemic changes that need to be there to allow people to use this information for the right reason.
Oh, that's great.
I'd
like to.
Can I
oh
jump
yeah,
in
go
on
ahead.
That
So
one?
you can respond.
I think,
yep.
well, we've touched on a couple of things. I think probably come back around maybe on privacy and security
Yes,
and what that means. But
that.
in terms of value, I absolutely believe that, and I think it's demonstrated that HIT brings value to organizations. I think one of the hard ones to quantify is workflow efficiencies. Yeah. You do see avoided utilization. You do see reduction in duplicate tests or unnecessary tests, and you certainly see avoidance of errors, which can lead to costs, certainly. Errors can lead to costs, but also outcomes that we don't want for our, ourselves and our loved ones. And I do want to, I'm going to use my cheat sheet here. I'm not so great with spewing out numbers, but we did just recently publish a study in the New England Journal of Medicine on the results of EMR and barcoding. And my director for clinical informatics at Brigham was the lead author of that study. And a few highlights. In terms of what they learned, 51% relative reduction in medication administration errors with the potential to harm patients. That's significant. That translates into about 90,000 serious administration errors prevented at Brigham alone in 1 year. So that takes us, to from your family story to that macro level in terms of broad impact. Second point, virtual elimination of order transcription errors with the potential to harm patients. And that translates into another 50,000 serious transcription errors prevented at Brigham alone in a year. So what we're seeing is that the impact of barcode and EMR deployment on patient safety is really comparable to what we saw with order entry many years ago, where there was a 55% relative reduction in serious prescribing errors. So those two together, very powerful in terms of adding value to the healthcare delivery, patient care and safety.
That's important. Thank you. That's great. I wanted to shift gears and focus what we were just mentioning about the whole question of privacy. Is there any privacy in any industry today? But related to healthcare, what we are seeing is, just to give you some context, the VA IT system has been recognized for years as being more advanced, capable system of sharing information across multiple sites throughout the country. However, in March, there was a software glitch on some medication in a medical record, and they had to shut it down and go to paper systems. Now, the question is really, what do we have for systems, and are we ready for that? But that happens with the paper systems, and sort of what's worse. It was just reported this week that 12,000 Medicare enrollees had their protected health information compromised when Blue Cross Blue Shield of Rhode Island donated a filing cabinet to a nonprofit organization without first removing the surveys that contained their personal health information. So it's an issue that happens electronic or manual, paper, it doesn't matter. But the question on the table for this group is, are we ready for the next IT security disaster that could happen? What do you see your organizations doing to be ready for that, and what do you think should be done to be ready? And I'll open that one up.
Well,
Go ahead, Sue.
I'll start on that. Are we ready? We're as ready as, we can be at this point in time, given the efforts and the dollars we've invested in it. Is there more to do? Absolutely. I can tell you at Partners, and this is one of the things that, in terms of all of our technical infrastructure, it's centralized at the partners level as opposed to at the site level. Our Chief Information Security Officer, who's been with us about a year, has had a pretty aggressive planning effort over the last year, once assessing where we were and where we still needed to get to. We are continuing to invest dollars and people there. Everybody's got to deal with, something as basic as laptop encryption. That may sound easy. It is not. A lot of blocking and tackling with all of your users on something like that. Education is huge. We're all shaking our heads like, oh my God, file cabinets moving with paper in them that they didn't look. I mean, how can that happen? But a lot of it does come down to education and making sure not only that you have your systems in place appropriately from a security perspective, but that every employee kind of owns that, understands that, knows what they need to be doing to protect information.
Great, good.
Yeah, I would add another funny story. It tells you how much technology has evolved, or the adoption of EMRs even. And 1980s, I was involved heavily with actually working on a project with Harvard Community Health Plan at the time to build the first commercial electronic medical record system. And the view was by 1995, we'd have 98% adoption throughout the country. But one of the things there was a lot of, obviously, concern about privacy and security then. And I happened to be, at that time, I was in the waiting room of one of the clinics because I'm going to meet with some of the doctors. And I'm reading this article that was written in the paper about privacy and security. And next to me, there's a fax machine just shooting out electronic medical records that are falling on the floor. And, and I'm sitting here going, something's wrong here. The real issue is, it affects everything, paper and electronic. The issue with electronic as we move there is just once it's out there, it's out there. And
it's at scale.
It's at scale. And are we ready? We've similar to that. In fact, tomorrow I have to report, because security and privacy reports up to me, and I have to report out to the board on things. We've had a roadmap too that we've evolved greatly. And yes, everything within our environment is encrypted, and everything we send out is encrypted, and we have the latest, greatest intrusion detection and every technology you could imagine to lock things down. But you can't always protect from people, okay? So and third parties. And even though the laws now, especially here in Mass, are very stringent about your accountability as a company for any third-party breach, so you're liable, and you are now responsible for reporting out if a breach occurs to third parties. That's a risk. And how do you audit or protect or ensure? Contracts are great, but that doesn't help you for a public issue. The second thing, of course, is people. Put something on a thumb drive, have a laptop stolen, all those, walk out the door with the wrong information. There are just, and that's the area that if there's anything we can do is the responsibility of individuals for privacy and security that I think is, we keep looking at it as a technology issue. It's much more than that.
Right. I was curious, Chris, if you could respond to whether you see security and privacy an issue in some of the work that you're trying to do with the open set process and the open order set?
Well, I mean, it's interesting because we work on the other side of the house. We don't actually have patient information per se. We have hospital process information.
Right.
And it's interesting when you speak about you've got analytical data which can predict pretty well who's going to have a heart attack at which time. But what you probably don't have is the ability to get those best practices to prevent that heart attack to the physician, right? So not only can't you inform the person, but there isn't a knowledge structure to get that out. And I think if we want to start seriously bending this cost curve, we can't just measure and predict. We need to start coming around. So to bring it back to privacy, so we don't deal directly with patient information, which makes our life easier, but we deal with this content structure and sharing across the network. And people have raised issues. Well, what if I use hospital A's order set in my organization and there's an error? Can people turn around and sue? So we run into those kinds of issues.
Interesting.
And in terms of what it's like to share and collaborate with best practices, and we've put a structure in place around where they agree not to sue each other, and there's a couple of other layers to it. So I think we've been able to get around that, but it is an issue we've encountered.
And I wanted Julie to respond to that question, but we're going to get ready to open it up. So I just want you all to be thinking about good questions. But Julie, if you could, your thoughts
This is
about
a
that?
subject that it's really easy for me to get on a soapbox on. I came to CMS in 2000, Amy mentioned that, and I came to run the information security program there. And at the time, they had just hired their first ethical hackers and had started looking at CMS's systems proper. And what they found, like many organizations when they start looking at their information security, was not pretty. And so would I tell you that we're great yet? No, we're not, but we're vastly better than we were 10 years ago and getting much better. But we do have accountability under what's called the Federal Information Security Management Act as a federal agency, that we have to hold ourselves and any of our contractors accountable to the same sort of rules that all federal agencies would do. So a way we interpret that is that when we hire contractors to do work for us, and we do a lot of business process outsourcing, we will go and check their security, usually before it goes into production. And time again, big companies, little companies, it doesn't matter. We find basic, simple mistakes. Things like, not patching servers. It's just really simple stuff, but really high-risk stuff. And I think that the industry that we're in, healthcare industry, really has to step up our game in this area because we're about to put this kind of technology everywhere, right? So it's one thing to have a hospital system like the one that Sue works for, running a big IT organization, but another thing for my doctor, right, who's just her, right, and she's a doctor, she's not an IT security specialist. And so, but I do think we have to resolve this because there's going to be a couple things that could really set us back. One would be a big, huge electronic breach on somebody's part who just went, and I think that would set us way back. And all I have to do is say VA, right? Because you probably, when she said that, you probably thought laptop too, right? In addition to
that was
the other stuff, right? And then the trust issue, right? Because suppose that those hospitals that my grandmother had to go to had been able to transfer information back and forth, right? Can the hospital actually trust that what they're seeing in that data and use it to make clinical decisions, which is where we really want to be. But if we don't have the trust behind the whole system, I don't think we're going to totally get all the bang for the buck. And I'll stop now because I'm telling you.
We know we can go on there. So we're going to ask if anybody has a question to please come up to the microphone, if you don't mind. If you could line up on either side here, that would be wonderful. And we'll open it up to your questions. And we've got, at least almost 25 minutes, so we did very well, I think. So why don't we, I think you raised your hand first back there, so why don't we start over here, we'll go here, we'll go back and forth. Okay, go ahead. Just identify who you are.
Sure. My name is Pankaj, and I founded a home care company where people can manage care themselves. And so I couldn't stop myself when you mentioned your grandmother. And because we actually let people do that themselves, and we are licensed in Massachusetts. The challenge, and I really want to bring this up because I think all the parties are here, is when we have a very advanced system, and they all are MRE technologists, who have really built a pretty solid web-based system of connecting people and downloading the health records, in any form or fashion you can think about. The challenge comes in when we go to a hospital and say, okay, can we connect our system to yours and we can download the files? What I don't understand is it the technology that is limiting, or is it people who are limiting that? And the impact of the IT in healthcare, which we talked about here, people are not seeing it because at the patient level, they're not getting the difference. I had a client who was 90 years old, very similar situation, and she had one set of records from one place and another set of records from another place. And she could see it very clearly how it was helpful to her. I mean, I just want to get your comments on that.
Great. I'll just take a stab at it. It is, there's technology components, certainly, for doing that, but often technology is not the rate-limiting step. It could have something to do with, whose information is that, who has to own and be accountable for that information, and can we share it with that third-party organization? So privacy rules and what the relationships are between the organizations. So often privacy and legal concerns are some of the hardest things to sort out when, in fact, the technology could support it.
This is actually one of those situations where maybe be careful what you ask for, because the health reform law specifically is incentivizing organizations to share information across these settings through these accountable care organizations. And if they actually can do that and actually show improved health or meet certain performance criteria, they will have savings that they can share among themselves. So the legislation is recognizing it. We'll see how far the technology goes and the people can go to align themselves to actually achieve this. And I think it's a combination. It's an important issue. Over here, question.
So, hello, thank you. One of my last projects was working with a company that was deploying a hacking product. So I learned more than I ever thought I would ever know about hacking, and on a network, end user, and web app level. And on a end user level, without becoming Big Brother on a system level, how do you think an innovation can be rolled out in a creative, educational way to help your end users understand the risks of how they're using the technology?
Are you asking a question about an end user awareness sort of program?
Yes. Yeah, internally within the system.
I'm a big proponent of information security training and awareness programs, but the evidence pretty much shows they don't work. And so you have to have technology controls to prevent the silly mistakes that can happen. But we still do a lot of it, and what I try to do kind of at my level in CMS is sort of give examples that are not related to why it's important for you to care about our information security, but just the fact that information security actually adds value to the business. So would anybody buy a book from Amazon.com if they didn't, make a big deal out of the fact that this is a secure transaction? They even say log into our secure server on the button, right? They're doing a whole lot to advertise the fact that it's secure, and I think that that's kind of the mindset that we have to create, is that it's not about securing and making business process harder. It's about adding value to the overall product that we're providing to our stakeholders.
Yeah, I would just add, I do believe, same thing, we have people taking tests, we have people,
Yep.
Campaigns, you have all this, and then you see the obvious thing saying, wait a minute, you didn't know that, the thumb drive you can't use after we went through all this. And so what we are doing more and more is getting all business areas more accountable to be involved in information security. So they're part of the team, and they're accountable for a role in it, which seems to help some. But I do believe there are some advances in technology, as there are, advances in cyber crime. That can help. So I do believe, and we're already starting to invest in it, is one of the key challenges we have is distribution of data. And that was brought on a lot by the evolution of distributed computing and PCs, et cetera. It won't be that far out where we're not going to be distributing PCs out there. Okay, we're going to be using all the data, and all the controls will be back behind like it used to be in the mainframe days, but we'll still be able to perform distributed processing because the processor will be on whatever device you have. So we will start to lock down those assets that leave the organization and get control back. And I think that will help a lot of this. But it is still something within our partnerships in what is the guidelines that are being put in place around these health information exchanges. It is going to require all of us to agree to these trusted relationships and operate that way. And I think there's a lot of thought process in there, but it hasn't been extensively implemented yet.
I have a question on this side. Go ahead.
And my question is more almost as a consumer of medicine. So the question I have is, what can we do as consumers to help you move medical records from one location to another safely, effectively, that I can own? Because my dilemma is I go from one hospital to another, just like you cited. I can't get my records moved from one hospital to another because of the safety concerns. I can't sign enough waivers to let them move the records from one to another.
So true.
And my medical experience is compromised, as is that of my parents. So is there an organization or a system or a company that's attacking this that I can sort of say, I own it, and I'm going to go from point A to point B with it?
Sue, did you want to talk about NEHAN? Is that
No, NEHAN
you
doesn't.
don't want to go there. Okay.
NEHAN doesn't do that. No, but
It's
I
not
think,
there.
I mean, what we're talking about is personal health record.
Yeah.
So like Microsoft's product
Google,
or
Google
Google's, Google Health. That's where they're trying to go, so that ultimately you own it. So the privacy issue isn't there because it's yours. You take it from one place to another. I'm certainly not an expert on how those are evolving or what the future looks like for that. But you also have at a more macro level the exchange between organizations. And over lunch, I heard a story. He said, work this in. And I'm going to generalize it, as we said. A question was asked it was at the governor's health conference a couple weeks ago. Question was asked maybe by the patient in this case or the doctor involved, but a doctor who left practice at one particular hospital to go be in practice at another particular hospital, and the day that that physician was done and their account was closed out, they lost all access to their patient's records. But much of their patient panel followed them then to the other hospital. And that physician couldn't get at patient records from the other hospital, obviously. And so the patient could go to the first hospital, ask for their record, and then bring it to the doctor. And when they asked for their record, they got their record on paper and brought it on paper to the second hospital. And when the CIO of the second hospital was asked, what are you going to do about it? I guess the answer was, well, when the first hospital is willing to give us the information. It is really not that simple. Someone else at the table said, are you kidding me? When did this happen? I said, well, whenever it happened, it could happen today, it could happen tomorrow, because, I mean, that's the state of where we are. But again, it goes back to who owns the records, issues around privacy, not necessarily technology in this case.
And the other piece to that, just to add to that, in terms of sharing the actual records is, if they give you the record, can you understand it in a sense? You mean there will be thousands of blood tests, hundreds of notes by different care providers. Will it be provided in a format to you that's understandable? Will the different consultants' notes match between the different organizations? So there's just giving the raw data at one level, but to use IT geek speak, there's a semantic interoperability issue, right? Will we actually have a sharing of meaning across sites? And that's the next layer. And then as a consumer, will this be provided to you in a format that empowers you, or is it just going to drown you in data? And I can speak to just in my own organization, we've got an electronic health record and we've got the ability to have online documentation. How do I put this? I can put documents in there that I know are going to disappear into the sea of data and nobody will ever see them ever again. So there's that second layer just between just sharing it.
And I would add under the meaningful use does tie to NEHAN a little bit. One of the unique things here in Massachusetts, we have a cooperative that we've all come together, the other payers, providers.
Yep.
It's a not-for-profit entity that we all funded jointly, and we sit on the board together, and we have a health information exchange. And about 20–25% of our administrative transactions throughout the state go through, when I say administrative, eligibility, claims type things. Obviously, with meaningful use, we've spent a lot of time talking about the clinical exchange, and all the challenges were just stated are there. And what we did finally reconcile, what we're really going to start putting in place to electronic care were really two things. One, e-prescription, so those kinds of, which is pretty well defined standard. The other one was discharge summaries. From the community, they thought the most important thing was to ensure that the doctors in the other hospitals had information related to the summaries around discharges. So those were kind of the interesting things that we are going to start sharing among those who participated in eHealth.
I want to move on, but I just want to say one thing. That you were referring to the New England Health Exchange Network. Okay, it's a really interesting organization. If you can check it out online. But the question really is the consumer isn't part of that yet. In other words, we're still not getting to his question, but you can see the struggle here. We're working on it. And we all hope that by the time we're all faced with those situations, we can somehow be, as a consumer, access that information. But it's a challenge. I'm going to leave it there because we're not going to resolve it today. I need to go on this side, and then I'm going to go on that side, okay? So here, yes.
Before I ask my question, I'll just volunteer 1 or 2 sentences on the gentleman who asked the question before about taking your health records and moving them around. And so one of the things that I adopted as a matter of policy years ago is my modest use of healthcare. I view my healthcare as more important than my financial records, and I keep good records of my finances, so I keep even better of my own health records. I have copies of all my scans and all my tests. If I go to a new place, I take my records with me, and I say, copy what we need. And because I own it, and so why should somebody be more responsible than me for moving my own stuff for my own care? This is me and this is my stuff. So, I mean, I think the challenge is to do it electronically so that there's a common format and I can put it in a secure file and stuff in the same way that I can download my brokerage statements and things like that. But I think that we need to get individuals to be empowered and to feel like they own and move and need to understand their own health records. So that's my view. Yes. So with respect to my question, so during the panel discussion, you all touched on the human factor of security. And so I'll ask my question by way of an anecdote, and this is closest to you, Susan. So there's a woman who lives in my community, and she works in a small doctor's office in the suburbs. And her daughter temps in that office sometimes. And so this small doctor, I mean, he's got a small private practice type of thing. He just signed up to LMR. So somehow if you're not part of Partners, you can be an LMR user. Her daughter had some extra time to kill and looked up random people and started talking to me about, oh yeah, I found this and I found that. And so I could get information about me, about somebody else, and so this is like a bleeding hose. And this is just one example. And so I'm wondering what we can do. Are there technology safeguards? Can you limit, are there tools that patients can do to say, I want this much access?
Excuse me, does she still have her job?
Yeah, I mean, she told me. I didn't rat on her. And well, you don't know who she is. And I mean, I told her, but I don't, the thing is that I don't think she's unique. I think there's tons like her out in the small practices.
It is I'm going to stop you there because it's a controversial issue, but why don't we try to get one response? I want to move on to
so my question is, what technology things can we put in place? Can we put, is there a technology solution to help contain this human foible?
Yep. So from a technology perspective, something called chart access control, where you have to, when you go into a record, declare your relationship to that patient, and that's all then part of the audit trail. I mean, so that's one piece of it. To take that further, if to have that relationship declared, verified, and if it's not verified, then to not be able to go into the record, obviously. But my gut reaction was the same as what a few people said, was she should be let go. She should no longer be working there because she has clearly violated policy.
Yeah.
Okay. We need to find out how to make that happen on a broader scale.
Thank you.
But there is a tracking system, so they know that she's doing that. I mean, somebody's not watching the store. But anyway, I'm going to move on because I know we could be here all day on that one.
So,
go ahead, Nancy.
So I just want to ask a question. I'm a clinical provider and strategist, and I'm very interested in relationship building. And because we're starting kind of a new wave of healthcare reform now, or a continual wave, if each of you had 30 minutes a day to spend talking to some new people across some new sectors to get some inflows of information that might help you in your role as you begin to develop new healthcare models of care, who would they be? Just really curious.
That's a great question. Jump in, guys.
So I already mentioned one, and that's really the financial services industry. And of course, a huge hot topic for us right now is figuring out ways to prevent Medicare and Medicaid fraud. And I think we've all had the experience of our credit card company calling us and saying, you know, did you make this charge? And in healthcare, we don't have really a really good similar model, though there are certainly some pockets of interesting intelligence that have been developed, so I think that that would be one. And then the other one I would look at is some of the, I think the retail sector, you know, that really sort of knows what products to put together to make people buy more stuff. And so it's more the data mining and analysis techniques that they do so that you can do even better types of predictive modeling or figuring out what certain payment reforms are going to cost and how you might implement them. So that would be mine.
I would say I would focus on teams and collaboration. And I think there may be something to learn from some of the most innovative companies in software development technology sector. And I think there's probably something also to be learned from academia and universities, especially with some of the stuff going on and how things have changed, let's say, since when I went to school, for students and sharing information, social media, et cetera.
That's great.
Yeah.
I am going to keep moving here
Okay.
because we have a few. We're going to try to get as many. We have about, a little less than 10 minutes, so we're going to just have to go as far as we can. Go ahead.
Hi, my name's Eric Brown. I think I have a two-part question. It might be a little bit more.
You can just keep it brief.
If we look to the future, the vision of everybody being connected, doctors, hospitals, insurance companies, government organizations, and sharing all this information in this vision of a good, perfect world. It sounds complex. It sounds like it's not reducing costs. It may be adding costs to the system. How do we get doctors that might be in an office of 2 or 3 doctors to effectively use the technology, to be able to maintain it, to provide the upgrades, the training, the ongoing activities that are required when they're not used to that, and that's an added expense. It just sounds very complex and expensive and hard to manage.
Yes, this is very much like the question we were going to get into about, how do we go from this cottage industry to more of a system, let's say corporate approach to this and systems that support practice. Anybody want to go for it?
I would say it's a huge challenge. I mean, I hear stories all the time in terms of the variability of use and practice within our clinician community for our electronic medical record. But, those systems have to be intuitive, easy to use, and along with that, we have to have the right level of training and support. I mean, I think you see I spoke at Wharton Healthcare Business Conference a couple months ago, and there were a couple students that I spoke to outside the presentation who were combined MBA, MD. And they were talking about the VA system being really wonderful in terms of how robust it was. And I think that a lot of physicians would say that about some of the systems that are legacy systems that we have at Brigham, but they are certainly not the newest user interface and as intuitive as anything you do now over the web. So we need to continue to move forward with those kinds of systems so that the training is much less.
Just briefly,
go ahead.
I mean, I think the usability issue is a huge piece. The other part that we're just starting now is the content or executable content. I mean, a computer is only as smart as the knowledge you put into it. In a sense, you can rebuild the blank order page inside a computer, right? You can put the most common orders used, but no intelligence. If we want to start changing care, we're going to have to start putting in our best practices into them in sort of an executable form that they can lead to improvements. And we're just starting to do that, and I think that's one of the enormous challenges in front of us.
Julie.
One of the things that's happening for the implementation of the high-tech provisions of the Recovery Act is the Office of the National Coordinator for Health IT is establishing regional extension centers, and their job really is to help educate the provider community about the use of EHRs and meaningful use and that type of stuff. And CMS, especially once we get past the final regulation process, will be moving pretty aggressively in outreach and education. So it's not a panacea, but it's at least the way to try to get some of the information out there.
That's great. I got to ask my group, do we have time for one more question? What do you think? One more? Okay, sorry, guys. Well, as I said, the panel, some of the panel members can't stay, and you'll have a chance to talk to them. Go ahead.
So it's a good last question, because I wanted to...
Oh, good. We wanted a good last question.
They've all been good.
It's very easy. We already discussed it.
It better be good,
It's not going to be
right?
hard. No storytelling. I'm not going to rat out anybody, although you're in trouble later. The notion of it is this has been a very bleak conversation about healthcare, but I know that healthcare does some amazing things with technology. I'm thinking like John Wade from St. Louis, the hospital in Kansas City, where they go into ambulances for people that are having strokes. They use wireless telemetry in the ambulance to tell the hospital, the guy's coming in, how far away he is, so the crash team's in the emergency room, and they do stroke intervention better than the national average because of technology. You guys have to have a couple, before these people all leave and think that, oh my God, the healthcare system's a mess. You have some anecdotals. I mean, you've got to have more efficient payments, the Blue Cross Blue Shield. I mean, you've got to have some uplifting stories of how technology is helping patients, right? And can you give a couple before we go?
Just a couple?
Yeah, you know, I commented on reduction
Thank you
in
for
errors,
that question.
significant reduction in errors.
Yeah, that's huge.
That's huge. I would point you to what's called Center for Connected Health, which is within Partners. They've got a website. They're on Facebook. They're on Twitter. They have a symposium in the fall every year here. And that's all our telemedicine, telehealth stuff. They're doing some really creative stuff and leading edge stuff. They're also launching a commercial company. They're basically licensing their core platform. The company at this point is called Hop, Skip, and Connect, though I think they're going to be, rebranding and changing the name. But many, many, many advances I think that we can talk about.
Yeah, I would add, and it's, often like insurance, how boring and everything, but there's a big part of our business. We do a lot of engagement with members around their care needs or issues they have, disease management. We also do it in a lot of wellness programs, behavioral health, and I can't tell you the number of letters that come in from people that through our web-based technology or things, we actually have an interaction with them, and they help them during a critical time in their life. Just they were struggling with an issue, a parent is dying, how to cope, everywhere through taking immediate action to actually save a life. And I mean, we get letters from that all the time, and it's directly associated with our ability to interact with them.
And you get more letters than you do missing filing cabinets.
Right.
Oh, yes.
That was Rhode Island.
I think that's the part I was trying to get to, is that for all of the one-time stories, the VA system goes down one time, they go to paper. Hospitals are built to go to paper. But that VA system's been running for almost 30 years.
Right. It was.
You know what I mean? So it can take a day break, right?
Right.
It can take a nap.
We just have to have systems in place to be ready for that. That's all. Did
So can I
anybody
put
want
it,
to add to that?
yeah, I'm sorry if this sounded bleak. I think healthcare is incredibly exciting. I've been in it a long time. I think all of us have. And I'm passionate about what we do. And I would also make a plug that the workforce for health IT is only going to grow. The projections are that over the next couple years, because of the stimulus funding and all that organizations have to do for meaningful use, that we need 50,000 plus new health IT workers. Those people have to come from somewhere. So if you're thinking about career changes, or young people who are looking at an area to go into, it's an incredibly rewarding area of work, and we need a lot of good, smart people.
I was shocked, Sue, when you told me earlier you have 1,200 employees in the Partners.
1,400 in Partners IS.
1,400 in the Partners health IT system across the
We do a lot
system.
of internal development. That's part of it.
Well, I wanted to thank the panelists for being here today, and I hope it was very educational. Thank you very much.